Having enjoyed watching many of the Rio events, I have looked forward to this conversation, and I've also written about this topic for both CardioSource World News and XL. So what I would like to do right now is talk to you about right ventricular remodeling in Olympic athletes. This is from the JACC Cardiovascular Imaging in August 17th issue, 2016. And I'm with Antonio Pisicchio, who is MD and Chief of Cardiology at the Institute of Sports Medicine and Science and the Italian National Olympic Committee in Rome. I've got to say, there's a vast literature that's evolved defining the structural and functional features of the trained athlete's heart. About 4,400 publications in PubMed is at like the last count. But at the forefront of this effort has really been you and your group. And first off, congratulations. And second, it's got to be fun.
Yeah. Thank you for this opportunity. Yes, so you're right. We were proficient in publishing several observational studies in this specific topic of the athlete heart, the physiologic cardiac remodeling. The reason is that because of we took advantage of the special program, special medical program of the Italian Olympic Committee that has been implemented for about 25 years. And this gave us the opportunity to make the unique observation on a unique population of very high elite athletes participating in a variety of winter and summer sport Olympic Games. So based on our database, this time we were really interested in understanding to which extent the right ventricle follows the changes of the left ventricle. You know, over the 20 years, there are hundreds publications regarding the left ventricular size, the atrial, left atrium, and right aortic, etc., etc. But in the most recent time, particularly thanks to the publication from Lagersh, from Buchel, there was a very new and large interest in right ventricular remodeling. The clinical question, the clinical burning question is that apparently in selected individuals engaged at a very high elite level in endurance sports, right ventricular remodeling actually goes from a physiological pattern to a kind of pathological pattern, including right ventricular enlargement, right ventricular dysfunction, presenting clinically with severe arrhythmias, ventricular arrhythmias. So the question that is underlying and that is still unsolved, are those athletes already patients because they harbor proclivity for the disease and the sport has been just triggering their, let's say, proclivity, or the sport itself may, for the right ventricle, be potentially harmful in a way that could be different from left ventricle or from the other side. So approaching this very relevant clinical question, number one, we should know which are the normal values of the right ventricle in athletes. And that's the reason for our study. So we took the advantage of our database. We do echocardiography by routine. It's a part of our medical program. There are no clinical indications for doing echo. So we do echocardiography, and in the echocardiography, obviously in the study, we include a specific assessment for the right ventricle. In this, more than 1,000 athletes that have been included in the most recent paper just published on the JACC Imaging, we had 1,009 athletes, including a substantial proportion of about 40% of female, including all kinds of sports, winter and summer Olympic disciplines, which were roughly distributed in different types of sports, including a very substantial subset, was about 30% of people engaged in endurance athletes. Endurance athletes for our clinical colleagues are cycling, marathon running, cross-country skiing, long-distance swimming, etc. All these disciplines have been shown in the previous time to be the most efficient in changing morphology and function for the left side. So our question was, number one, to what extent right ventricle is changed in athletes in comparison to normal untrained individuals, and particularly to what extent this right ventricular remodeling can alter substantially the morphology and the function in endurance athletes. In this study, we actually provide the information for the normal values that you can derive from the long axis view and the parasternal short axis view. Those are the images that are utilized by the task force to assess the normal values or to define normal or enlarged right ventricle. So we saw that globally the population of the athletes do present an enlarged right ventricular outflow tract. You can measure for both images, both views, and we provided the normal values. We provided the 95th percentile of the normal values separately for male and female athletes, which are, if we refer, for instance, the parasternal long axis, 32 millimeters for male, 30 millimeters for female. And there are also similar values, 30 and 32 in the parasternal short axis. So dimensionally, the right ventricular outflow tract is increased. But the first characteristic, this is one of the criteria that can be utilized in the clinical ground for differential diagnosis. Number one, right ventricular outflow tract is enlarged, but at the same extent, the right ventricular inflow tract is also enlarged. So there is not disproportional enlargement of the inflow and the outflow tract. If you see the patients that has been described by Cristina Basso and the other pathologist colleague, the disease mostly affects the outflow tract. So you have a kind of a disproportionate, kind of abnormal shape of the right ventricle. Going more into details, the right ventricular enlargement is in some way proportional and symmetric with the left ventricular enlargement. We made a relationship between diameters of the left ventricular cavity and basal diameter of the right ventricular cavity. There is a linear relationship between the two. That means then when you have an enlarged right ventricle, you have a suspicion if it is normal or not normal, you should also consider the left ventricle. And if there is a balanced, symmetric, harmonic enlargement of the right and the left cavities, this is like very likely is a kind of physiological remodeling. However, in a proportion of these athletes, particularly endurance athletes, if you have a qualitative assessment of the right ventricle, you can find some pain peculiarities that may rise doubt. For instance, the apex could be a little bit more rounded, may have a kind of a round shape. This is present in a substantial proportion of the athletes, more than half of our population. Most likely this is a part of the global right ventricular remodeling, the global enlargement of the right ventricular cavity. But also, for instance, a kind of prominent trabecular pattern with a very bright moderator band or prominent, very visible trabecular pattern can also be observed in about 30% of our athletes. So if you look only at this specific feature, you may be, let's say, misdiagnosing. You have to see the overall picture. And the overall picture says that dimensionally the right ventricle is enlarged. Occasionally you may have also so rounded shape apex, trabecular pattern. However, the function is always preserved. In particular, no one of our athletes showed a global right ventricular dysfunction, and no one, this is even more relevant, no one of our athletes show segmental wall motion abnormality. So if we can transfer this information into the clinical ground, and we compare our dimension with the dimension, the threshold values that are utilized by the task force criteria, and you look only the dimension, there is a substantial proportion, up to 40% of our athletes that meet the minor task force criteria in terms of dimension to be labeled as possible. And if you look at the major criteria, major dimensional criteria, there is still a substantial subset of the athletes that meet the criteria for enlargement. 16% in the parasternal long axis view and 4% in the parasternal short axis view. So in individual case, dimensions don't tell you the truth. Dimension can mislead you. So what you have to see is to see not only dimension, not only enlargement, but mostly function. And when the function is totally normal, and when there are no wall motion abnormality, and then you have to ask, what kind of training, what kind of sports are you participating? And if it's an endurance type of sports, so you have mostly all the pieces of the puzzle put together, and you may very likely define this a kind of physiological right ventricular remodeling. Finally, I want to say that we obviously are starting a very close follow-up of the athletes with the enlarged right ventricle. Because although we believe that the right ventricular remodeling we describe in this paper is a completely physiologic phenomenon which actually parallels the left ventricular remodeling, however, we cannot exclude that there is maybe someone of these athletes with maybe a concomitant appearance of electrocardiographic changes or maybe arrhythmias and enlargement that deserves a more careful clinical evaluation, including MRI, including evaluation of the arrhythmia profile, and obviously a long-term follow-up. However, in conclusion, I would like to say the message that we should deliver to the clinicians is that the athletes, they do enlarge the right ventricle. The extent of this right ventricular enlargement in endurance athletes, particularly the elite and the male athletes, is substantial, and they may generate doubts of differential diagnosis with arrhythmogenic cardiomyopathy. In this case, you have to see mostly the function, the right ventricular function. And the right ventricular function, the assessment of the function, gives you the key to differentiate the physiology from pathology.
Now, there was an interesting piece of artwork that you used in JACC imaging. So what are we looking at here?
We are looking here at the major information are the dimension. We provided the 95 percentile dimension that can be utilized as upper limits for dimension in the right ventricle. Then we define the limits for fractional area shortening, which is an index that is widely used in the clinical setting for assessing right ventricular function. We define the lower limit is 38%. So fractional shortening lower than 38% should be viewed with the caution.
In helping to guide clinicians, the one thing I was noticing, is I just wrote about this recently for Excel, the differential diagnosis of athlete's heart at ARVC remains a difficult clinical problem. I mean, that's one of the things that I came away with from your paper.
Exactly. You're totally right. This is due not only at the relatively lack of the information that so far have been published on the right ventricle, but also is related to the imaging techniques, particularly. As you know, the echo imaging of the right ventricle is relatively poor because of the several technical limitations. So you need a very skilled people, a very nice tool, but eventually also the cardiac MRI, which is considered now the gold standard technique, the imaging technique to assess the characteristic and the function of the right ventricle, also has the power, has the limitation of the knowledge by the interpreting physicians. Because, interpreting the right ventricle and assessing if there is any hinge of abnormality, it's a quite difficult task. The specific knowledge of the radiologist and also cardiologist doing imaging is still relatively limited. And so at this time, what we have to fear more is overdiagnosis of arrhythmogenic right ventricular cardiomyopathy.
I've got to ask, in the Olympic athlete population that you deal with, are they really interested in the results that you get? Do they ask you about it, or do they go, I don't want to know, I seriously don't, I've got work to do? What's the athlete's response to the studies that you're doing?
Very nice question, very interesting. I have to say, in the larger population of the young individuals that came to our observation, there is a broad variety of reaction. There is, let's say, the more acculturated people, they are quite interested. They're quite interested because they understand that these results goes into a kind of package of information that is actually utilized by the coach, by the trainers, to adapt also the physical conditioning and to follow the schedule of their training. There are also less interested people that just they enjoy practicing sport and they just have the fear that we can find something abnormal that may interfere with their career, which is totally understandable. But that's also the reason because we do the cardiovascular evaluation in this very selected population of the athletes. I think that there are not only ethical motivation as a physician to do the evaluation of the athletes, but there are also legal instances that we follow in order we really want to be sure that these individuals that represent our country are truly normal. And there are also kind of, let's say, cost efficiency. Each one of these athletes reaching the Olympic level is not a naive athletes. It's the results of several years of training, education, skill, expertise. Is the target of a lot of investment, not only in culture but also economic. So we really want that they compete to their maximum and without any special risk.
Well, that could describe you, the 25 years of skill and training and effort and expense that you've put into all of this research. Are there still questions that you're hoping to answer in the next 5-10 years?
A lot.
Are you still excited?
Pretty much. You are asking, but I have to say the answer is I still enjoy. I still enjoy doing my job, and this is my major strength and my motivation to go ahead. There are a number of issues that we really want to know. Number one, the long-term effect of the remodeling on the right ventricle. We really want to know. We want to be able to distinguish the few people that may get harm from the larger majority that they don't. And indeed, there is a large room for implementation, larger implementation of the physical activity and the sport practice among the general population, including old and senior athletes, which actually may benefit from this activity to much more a larger extent than the young.
It is always great fun to chat with you, so thank you very much.
Thank you for the opportunity.
Please make sure you check out the August 17th JACC Cardiovascular Imaging issue so that you can read this paper. And also, thank you very much for listening from CardioSource World News and CardioSource World News Interventions. I'm Executive Editor Rick McGuire.